Good evening, everyone. Thank you for joining us for a decade of robotic knee and hip replacement surgery webinar with Dr. Dounchis. Dr. Dounchis has more than 28 years of experience as an orthopedic surgeon and takes great pride in taking care of his patients in Southwest Florida. He graduated from Harvard and Johns Hopkins University School of Medicine and also trained at Mayo Clinic. So, Dr. Dounchis, go ahead and take things away.
Thank you, Rebecca. So everybody, thank you for taking the time to participate in this overview of robotic joint surgery. We're going to take a couple minutes to review some of the relevant anatomy, technology, and then incorporate those concepts into modern robotic joint surgery. First, just a little review about arthritis in the knee. So as depicted here on the slide, you have the femur bone and the tibia bone and that smooth surface on the left slide there in the opaque pink tissue plane there at the end of the femur and tibia. That's called cartilage. And cartilage is a 5mm coating. It's like the brake pad that coats the brakes. It allows for a near friction-free environment between bones where they articulate. So it's not just the knee joint, all the joints in the body have cartilage. And for some of the same unique properties that imbue the cartilage with such a friction-free environment, unfortunately, the material itself does not have the intrinsic ability to heal, as does the bone or skin. So in other words, if you break a wrist and put it in a cast, the bone heals, and a couple years later, you couldn't even tell that there's a fracture there. When the cartilage gets injured, again, that's the coating that coats the bones, unfortunately, it does not have intrinsic capacity to heal. There's no blood supply. There's not a lot of metabolic nutrients to the area. The cells that provide sustenance to the cartilage matrix do not have the ability to heal, unlike bone cells or osteocytes. And the geometry and architecture of the cartilage is a very complex multi-layer architecture that's difficult to recapitulate. Over time, over half of Americans will end up with enough wear and tear of that joint surface, i.e. knee osteoarthritis, to benefit from treatment. And to the right is depicted an arthritic knee. Becca, if you could pass the next slide, please.
Yeah, I'm trying to hit next. Here we go.
So fortunately, many of our patients do very well for a number of years with non-operative treatment. That includes therapy, low-impact strengthening exercises, anti-inflammatory medications, acetaminophen. There are multiple injection opportunities. Cortisone and Synvis, which is the most commonly used brand of visco supplementation, can be very beneficial, particularly in the mild to moderate arthritic phases. Arthroscopy has an interface with arthritis when there are significant meniscal tears or mechanical issues in the knee with mild to moderate arthritis. When we pass the moderate arthritis stage, arthroscopy becomes less beneficial. And we need to start thinking about ways to actually repair the joint surface. And that's where partial and full knee replacements play a role. Next slide, Rebecca. Thank you. So depicted to the top right is a partial knee replacement. You can see just a portion of the knee surface is replaced, in this case on the medial side. And in the bottom right is a full knee replacement. Next. And down the bottom, we go from mild arthritis to moderate to severe arthritis. So depicted in the bottom left, we have just a small dime-sized defect in the articular surface. That with coexistent meniscal issues or mechanical symptoms from loose fragments in that area can be properly treated with simple arthroscopic techniques addressed above. When there's just one compartment arthritis is depicted in the middle bottom slides, or one or two compartments are predominantly involved with arthritis, but we still have good articular surface on the contralateral compartment. Then a partial robotic surgery is indicated, and then when all three compartments of the knee are involved, then full knee surgery is indicated. Next. So why robotics? So starting in 2009, our center here at NCH began investigations and treatments with robotic technology. This was actually a thoughtful next edition technology from the era of computer navigation, balancing sensors. So there's been over 30 years of research and development and active clinical treatments utilizing computer navigation and advanced tools to better optimize alignment and implant placements in orthopedic knee and hip surgery. The robotics takes it one step further. The robotics allows us to integrate a three-dimensional model of the same exact bone structure based on CT data. So we have a 3D model of the patient's actual bone anatomy from the hip and spine all the way down to the ankle. In addition, we make measurements in surgery to ascertain the proper function of the ligaments, the kneecap, and that way we determine exactly what the normal architecture was of that knee 20 years ago before the knees started wearing out. So now we know exactly the proper goal to reestablish the normal architecture of the joint. And that's always been the challenge with knee arthroplasty and hip arthroplasty, is we're trying to resurface a three-dimensional structure in proper mechanical alignment in 6 degrees of motion. And the 3D technology imbued by the robotics allows us to precisely restore that anatomy. So herein is depicted some of the planning slides for the robotic procedure, and down below is the robotic device itself. And you can see there's an end effector. In this case, that's a small burr that's utilized to prepare some of the roughened bone surfaces to shape it just perfectly so that the implants are placed in a 3D fashion. So the benefits of partial robotic knee surgery, and we just published 10-year data now in the Journal of Bone and Joint Surgery on partial robotic knee surgery, is not only a more natural feeling knee, but a much more durable construct, easier rehabilitation, and outpatient surgery. So now with over 10 years of clinical data, we've established not only the durability of the construct, but much more natural knee athletic function and simple recovery process. So building on prior computer navigation and custom balancing, we've integrated the robotics to full knee surgery as well. Next slide. And full knee surgery involves resurfacing all three compartments with the same additive benefits as described for the partial knee. Now the hip joint, just a little review on the hip anatomy. The hip's different macro architecture. So again, a ball and socket articulation. The cartilage surface, again depicted in pink here, is 5 millimeters thick in the hip as well. You can see to the right where we have worn the articular surface down to the bone area. Next slide. And the 3D planning phase and then implementation with the robot allows us to accurately reconstruct the hip center of the rotation in 6 degrees of freedom. You can see from these slides here, all the extra bone extrinsic to the green surface area here. That's all extra osteophytic bone or non-normal bone that's formed over time in response to the arthritic process. And this type of technology can really enable clearly delineating the proper mechanical goals for this joint reconstruction and achieving those goals as will be depicted. Next. So similarly, the end effector on the robot is geared for hip arthroplasty. You can see the little polishing device down at the bottom left of the screen. Next slide. And these are some of the work phases where we go through actual treating and reconstituting the normal center of the rotation of the hip. Next slide. And the robot helps guide us with placement of the acetabular component, which is a thin acetabular shell of titanium. Next slide. We'll show some slides at the end. And we can guide exactly the position and orientation of the acetabular component. Next slide. And we check those positions as a secondary check. Next slide. And this is just kind of overview of hip arthroplasty. So modern hip design, the femoral head is a ceramic material. The titanium shell there is lined with a very special cross-linked polyethylene liner. So the polyethylene, compared to prior generations of polyethylene, has been cross-linked to provide further durability of the material. And this has been a substantial improvement for our patients in both knee and hip arthroplasty, with this polymer being extraordinarily durable compared to prior generations of polyethylene. Next slide. Many questions arise about the interaction between the approach to the hip and the robotics and then the actual implants. So to work on the hip, you have to obtain exposure to the hip joint. There are several different approaches or exposures to the hip joint. In prior generations, the more common approach was what's called a posterior approach, which goes from more the gluteal posterior area. It does require going through several muscle planes and has the distinct disadvantage of an increased dislocation rate and less ideal function of the muscles given the approach. The anterior approach, therefore, is gained marked favor in the United States, particularly since the 1990s, late 1990s. It's been used particularly in hip arthroplasty in North America, and that involves an approach from the front side of the hip, which does not remove any of the muscles around the hip joint. We just simply go in between two muscles as depicted up in the right slide there. And this markedly facilitates rehabilitation. There are no restrictions after the procedure, and the muscle function is maximized after surgery. Next slide. So let's take a step back and reiterate and overview the implications and evolution of robotic surgery. So starting again in 2009, we embarked first on the partial knee platform, then the total hip platform, and then the total knee platform, utilizing three-dimensional, robust imagery of the entire extremity, both for the knee and the hip procedures. This is based on CT technology. In addition, both pre-op and in surgery, we add further information regarding the joint function with regards to the ligament function, kneecap function. So in other words, further measurements are made intraoperatively to further determine the natural function of that joint. Now, with all that information in the system, we can accurately determine the natural ideal function and position of the joint. And then we utilize the robotic technology to properly place the new surfaces in a three-dimensional fashion so that the natural architecture of the joint is reestablished. The ligaments and the mechanics of the muscles around the joint are now back to their optimal position. And we have found patients get not only better motion, but they have more athletic natural function, more natural feeling extremities, and the implant survivorship, which is critical as well, has improved dramatically with optimal implant positioning and treatments. So again, the robotic technology facilitates recapitulating the normal architecture of the anatomy where it was before the arthritis ensued. This is the standard of care for our patients with both knee and hip arthritis. These procedures involve regional anesthesia, meaning no general anesthesia, no tube or endotracheal tube. The anesthesia team places a spinal block, which is local anesthetic in the neuraxial spine, which effectively numbs the extremities for 2 hours. This is supplemented with typically 2 additional blocks in either the knee or the hip area. So cumulatively, those blocks together have lasting effects for the comfort of our patients in the initial recovery phase. That mitigates symptoms, allows for early function and mobilization, reduces the need for narcotics and other medications and possible related side effects, has facilitated early recovery and allows for same-day discharge for appropriate patients. The soft tissue treatments have been markedly improved as well. The vast majority of patients do well with a plastics closure with a glue dressing. So the final layer on the skin is not staples or sutures. There's no materials that need to be removed. The final layer is a glue closure, which remains for 4 weeks. It's like a piece of Scotch tape that's well adhered to the skin. Patients are allowed to shower the day after surgery without any covering on the extremity or the incision site, facilitating post-operative hygiene. And that glue dressing is removed at 4 weeks, and a couple of days thereafter, patients typically are allowed to embark on swimming or aqua exercises as well. So again, I want to thank Rebecca for moderating this webinar regarding robotic technology and appreciate everybody's participation. Thank you, Rebecca.
Thank you, Dr. Dounchis, and thank you all that joined us. We hope you'll join us for Dr. Dounchis' next webinar on shoulder, rotator cuff, and arthritis on Wednesday, September 20th. Hope everyone has a great evening.